Good afternoon. Today we're talking about diabetes mellitus, which is found in chapter 33 of the current textbook. Before we really begin on diabetes, you have to have a basic understanding of how the body works. So this integrity lecture that I'm going to do is going to focus more on the pathophysiology of why things are going to be happening. So we're going to start with the normal body functions and how things are supposed to normally be working. And please understand that this lecture on integrity is not going to be all inclusive. I'm not going to be as focused or in detail as the book or as the lecture during class, if there is a lecture during class. So I want you to know that I'm hitting the high points, or else this lecture would go on for a very long time. So the first thing you have to understand is the way that glucose, fat, and protein are metabolized in the body, and the way that the body uses those up. The body uses glucose, fatty acids, and other substrates for energy. So the liver, along with insulin, which we're going to talk about, control the storage and mobilization of the body's fuel supply. When glucose comes in contact with oxygen, it breaks down to form carbon dioxide and water. The body will actually use fatty acids and ketones as fuel, with the exception of the brain. The brain cannot utilize fatty acids or ketones. It exclusively relies on glucose as its main fuel. The brain doesn't have the capability to save up or keep a reserve of glucose, and so if blood sugar levels drop, it can cause problems in the neurological system pretty quickly. Severe prolonged hypoglycemia, which we'll talk about in a little while, causes brain death, and even moderate hypoglycemia causes brain dysfunction, such as like confusion or impaired thought processes. 2/3 of the amount of glucose that you eat or ingest with a meal is actually removed from the blood and stored in the liver or the muscles, and those two organs will store that as glycogen. The rest of that 1/3 of the glucose that you eat is actually immediately dispersed and broken down and given to the cells. So 2/3 of what you eat is actually going to be stored as glycogen. When the liver and the muscle cells become saturated with glycogen, then what's left over, or the excess glucose, is then converted into what we call fatty acids. The liver does that. And then they're stored as triglycerides in the adipose tissue, or the fat cells. So when levels drop below normal, the liver converts glycogen to glucose in a process called glycogenolysis. So glyco meaning glycogen, genolysis is the breakdown of glycogen. So what it does is the liver breaks down the glycogen that it has stored up, turns it into glucose, and then releases it into the system. And that happens when our body senses that our blood glucose is low. In addition to mobilizing glycogen stores from the liver also will make and synthesize glucose from amino acids, glycerol, and lactic acid. And this term is called gluconeogenesis. So it's the making of new glucose. So gluconeogenesis and glycogenolysis both occur in the liver in response to a low blood sugar, and in an attempt to maintain or normalize the blood glucose levels. Fat. Fat is our most efficient form of fuel storage. It's a major source of energy for the body. Excess carbohydrates and proteins are converted into triglycerides, which we store in our fat tissue. Fatty acids are transported to the tissues where they're metabolized for energy. This is facilitated by enzymes known as lipases. I'm sure you've learned back in nutrition about the calorie expenditure, but fat provides us 9 calories as opposed to carbohydrates, which is like 4, I believe. So basically, your fats are your major energy source for the body when we're at times of rest, as well as physical activity. So the next one is the proteins. Proteins. They're essential for the formation of all body structures, genes, muscles, the matrix of your bone, hemoglobin, red blood cells, and many more. Protein, these are amino acids. They're the building blocks of proteins. So anytime you see something that has to do with amino acids, know that amino acids will build up and make form proteins. The body does not store amino acids as much as they do glucose, and so excess amino acids are actually converted, again by the liver, into fatty acids and ketones or glucose, and then they're stored as fuel or for fuel at a later time. So that's a little bit about how the body uses glucose, fat, and protein. And that's important because we're going to talk about some disorders that are going to be disorders of protein metabolism or glucose metabolism and so forth. So you have glucose regulating hormones. The two that we're going to focus on are insulin and glucagon. Insulin is the only hormone known to us to have a direct effect in lowering blood glucose levels. Insulin, the action of insulin is threefold. Basically, it promotes our tissues to take up more glucose, so it promotes glucose uptake by the tissues. It prevents fat and glycogen from being broken down, and it inhibits, or it stops, gluconeogenesis and increases protein synthesis. So what that means is when our blood sugar is high, insulin comes from our pancreas. The beta cells in our pancreas secrete insulin in response to elevated blood glucose. The insulin comes out and tells the cells in the tissues, take in more glucose, take in more glucose. Then it helps tell the rest of the body and the liver and so forth, don't make new glucose from the proteins and amino acids and things. We want to increase the making of more proteins, and we want to prevent fat and glycogen breakdown. There's no need for that. So basically we get insulin, it kind of regulates the blood sugar and helps bring it down by working on the tissues, stopping the glucose uptake there, also preventing fat glycogen breakdown, and stopping gluconeogenesis. Insulin, it does promote fat storage. It facilitates triglyceride synthesis from fat cells, and it inhibits protein breakdown. So it stops us from breaking down proteins and helps us make protein. So it increases protein synthesis. There's a good table, 33-1 in your book on page 795 that gives you some good examples of what I'm talking about here, and kind of reiterates all this. So again, the release of insulin is from the beta cells in your pancreas, and it's regulated by blood glucose levels. As your blood glucose levels rise, and then you're going to see more insulin. As they fall, you'll see less insulin. Diabetes may actually result from a dysfunction or a deficiency of any of these steps involved. So serum insulin levels will rise within minutes of eating a meal, and they'll peak within about 2 to 3 hours. Insulin is usually rapidly bound to the peripheral tissues, or it's destroyed in the liver or the kidneys. Insulin has only a half-life of 5 to 10 minutes. It binds to the receptors to initiate effects. Glucagon, on the other hand, is a polypeptide produced by the alpha cells in the islet of Langerhans. It helps maintain blood glucose levels between meals and during periods when we fast. So during long periods of time when we don't eat, the glucagon is what we use to regulate our glucose. So like insulin, it travels through the portal vein to the liver, okay, and here it exerts its main action. So glucagon's main function or main action takes place in the liver. And it stimulates or it initiates the glycogenolysis, which again was a breaking down of the stored glycogen to make glucose so that it can be used as fuel. And this usually occurs within minutes of recognizing a low glucose level. It also increases the transport of amino acids into the liver and stimulates their conversion into glucose through gluconeogenesis. And that again kind of is the maintenance part. It takes a little while to do that, and it'll maintain our glucose over time while if we're doing a long fast. So low blood glucose stimulates an immediate release of glucagon from the alpha cells in the islet of Langerhans, and elevated blood glucose inhibits the release of glucagon. But when our blood sugar is elevated, remember that it stimulates insulin production. So this is an excellent little chart that I found that I think is a good representation of what is really going on. We're talking about two major organs, the pancreas and the liver. We've already talked about the liver in class, so you got to remember, and you got to bring everything that you've known about liver to this process. If somebody has liver failure, right, they're not going to be able to do these things appropriately. On the other hand, if somebody has acute pancreatitis or chronic pancreatitis, the pancreas is not going to work and do the things that it needs to do. So it's very, very, very important that you get a grasp of what is occurring in the body and what is supposed to happen and what's the normals. That way you can understand these diseases a bit better. So diabetes. Diabetes is a disorder of carbohydrate, protein, and fat metabolism. Okay, we just talked about what those were supposed to do. It's an abnormality in the blood glucose regulation and the abnormality in the nutrient storage related to a deficiency of insulin, or could be a resistance to the actions of insulin. So there are three main causes when we talk about diabetes. So one of the causes is either number one, there's not enough insulin, okay, being produced by the pancreas. Number two, maybe there's enough insulin that the pancreas can make, but there's an impaired release of that insulin, so it's not getting out of the pancreas. Or number three, maybe the receptors on the tissues are resistant and not wanting to take up the insulin that is circulating. So in the third part, the third cause would be a problem with our tissues, and it's called insulin resistance. Basically, the pancreas is working, and it's actually going to end up working at overtime and producing more and more insulin, but our tissues are resistant, and they're not wanting to, the receptors are not wanting to take up the insulin that's circulating and not wanting to suck up the glucose. So that's pretty important. So let's talk a little bit about the different types of diabetes mellitus. Your book goes into 4 different types. You have type 1, type 2, gestational, and then secondary. So we're good as we progress through this, we will talk specifically about these disorders. But before we move on to each one of those particular types, let's talk about real quick the blood glucose test and the risk categories of risk. So these are going to be very important. You're going to have to know the numbers. You're going to have to remember all this. This part is going to be truly just memorization. I try to get you away from that, but on this slide, you're going to have to memorize the numbers. So basically, a fasting plasma glucose initiated as FPG measures glucose levels after food has been withheld for 8 hours. So fasting means not eating. Plasma is the blood, and glucose. So if you need to get a fasting plasma glucose, the patient cannot eat for 8 hours, at least 8 hours, before drawing this blood level. Your oral glucose tolerance test is a measure of the body's ability to remove glucose from the blood within 2 hours of consuming a fairly large dose of glucose, typically 75 grams. And so what we do is I'm going to give you some numbers of these and tell you what that means to be impaired and what is normal. But you have to understand what they mean to begin with. So a normal fasting plasma glucose would be a glucose level less than 100. Okay? Or a normal oral glucose tolerance test would be a glucose level less than 140. So if I had a glucose reading, let's just say you drew a fasting plasma glucose level and I was between 100 and 125, that would put me into the category of impaired fasting plasma glucose, or an IFG. So I'm a little bit high, but I'm not necessarily in the high abnormal range. I'm just a little high. I'm impaired. Okay, So 100 to 125 is impaired fasting plasma glucose. Again, if they've drawn it with an 8-hour fasting time. If they do an oral glucose tolerance test, and I run a blood sugar of 140 to 199, then I would have an impaired glucose tolerance test. Okay, so the normal fasting plasma glucose, normal is less than 100. And we're going to talk about hypoglycemia, so it's not, obviously 0 wouldn't be normal. I think 70 to 100 is what your book gives us as hypoglycemia, but we'll talk about it when we get there. But less than 100 on the high end is normal, and less than 140 is considered normal for the oral glucose tolerance test. If it falls between 100 and 125, it's in the fasting glucose, that would be impaired. If it falls between 140 and 199, that would be an impaired glucose tolerance test. All of these glucose are determined by a blood draw, not a finger stick like you see people do at home, but an actual stick in the facility where they stick you with a needle and they draw out your whole blood. And there usually is about a 10 to 15% difference in the readings that you get from somebody that sticks their finger versus getting whole blood. So just know that the whole blood is going to actually give you a more accurate, higher reading. But people with impaired fasting glucose and impaired glucose tolerance tests are often referred to as having prediabetes. And that increases your risk for future development of diabetes as well as cardiovascular disease. So key things here to why does it really matter? We want to prevent this from happening. So weight reduction and calorie restriction are very important to people who are overweight with prediabetes. Okay, so HbA1c, that's a hemoglobin A1c. We're going to talk a little bit more about this one. It's used with chronic hyperglycemia. It reflects a daily average of glucose over about a 2 to 3 month period. So if I drew an A1c level today, it would tell me about what my glucose has averaged every day for the last 2 to 3 months. We use it now to actually aid in our management of diabetes, but the new recommendations are that it be used to diagnose diabetes, and we're going to talk about that. So an A1C level less than or equal to 5.6% would be normal. An A1C level of 5.7 to 6.4% means that you're at risk, and that's at risk for having and developing diabetes. And greater than or equal to 6.5% can be diagnostic for diagnosing diabetes. And we will get to that again in just a bit. So, diabetes mellitus type 1. Again, destruction of the beta cells that results in an absolute lack of insulin. It's leading to hyperglycemia and fat and protein breakdown. We see this one in about 5 to 10% of cases. And of those 5 to 10%, 90 to 95% are type 1 cases or type 1A, immune-mediated diabetes, because there's two different types of type 1. There's immune-mediated, and then there's like idiopathic, which means they don't know why or what causes it, and that would be the type 2. So we're focusing mostly on type 1A, immune-mediated diabetes. So basically, with type 1, it means that the patient is more likely prone to develop a condition called DKA, or diabetic ketoacidosis, which is a complication that is discussed further down in your slides. But when insulin is not present, we talked about this already, lipolysis or fat breakdown, or the release of fatty acids, ketosis developed from fatty acids after being released and converted to ketones in the liver. A patient with type 1 diabetes will require exogenous, meaning not inside the body, something that we actually have to administer. So like pharmacology, we would have to administer insulin to these patients in order to prevent the process of ketosis. Okay. Type 1A, the immune-mediated, was formerly called juvenile diabetes because it is seen in such a younger population. Typically, our young adults, young adolescents, kids, it's usually type 1 diabetes that we see here. We know that there is a genetic predisposition along with environmental factors or environmental triggering events, such like an infection or a hypersensitivity reaction, those things occurring with some genetics, genetic predisposition. We know that that can cause this type of diabetes to occur. The fact that type 1 diabetes is thought to result from an interaction between genetic and environmental factors led research into methods directed at prevention and early disease control. So, we're going to talk about the manifestations in just a bit, but this was kind of like a little bit of the intro. With type 2 diabetes, diabetes type 2, this is again hyperglycemia, but it's with what we call relative insulin deficiency. Whereas type 1 is an absolute lack, the pancreas is not working at all. This one is a relative insulin deficiency. And again, 90 to 95% of cases that we see every day are type 2 diabetes. So this one would be more prevalent than type 1. Most people with diabetes mellitus are overweight, and they're usually older in age. What we see is more commonly occurring now in our obese children and adolescents because obesity is becoming such a prevalent disorder of the young people. We're starting to see diabetes type 2 occur more in those children now. However, as a rule of thumb, I want you to remember type 1 diabetes is typically occurs in our younger patient, whereas type 2 occurs in the older patient. More common in adults over 40. Okay. Metabolic abnormalities that are involved. Again, either insulin resistance. Okay, so the tissues don't respond to the circulating insulin, or increased glucose production by the liver. So for some reason, the liver is not responding or not understanding from the feedback system, and it keeps putting out or making more glucose. Or there might be an impaired secretion of insulin from the beta cells of the pancreas. So our pathogenesis of diabetes, when you look at your book, it talks about a positive family history, specifically a first-degree relative. So genetics plays a humongous role in this one as well, even more so in type 2 than type 1. I apologize. It's strong genetic history in both of these. I don't want to say that, but so type 1 typically we didn't count on being genetic. That is a new finding here recently. So they both do have some genetic and familial history. We're going to talk about acquired diabetes type 2. Acquired meaning we develop it based on diet, lifestyle, so obesity. Central obesity, meaning fat around the midsection. Specifically, people that have visceral obesity, so lots of fat around their visceral organs in the abdomen. And like a high metabolic index or an elevated BMI, that would indicate obesity. That would be a reason or a cause. And what we see is metabolic syndrome is more common in type 2 diabetes. We're going to talk just about that. This is a picture that I thought was pretty relevant that you should look at. Again, it kind of shows you type 2 diabetes. She's sedentary lifestyle. She's overweight. You can see she's all scratched up on her legs and probably has some infections and complications going on, and I'm going to talk about those. She's eating sugars and chocolates and sweets. We'll see a history of high blood pressure. Their fatigue will be really down in energy. It says average age is 50. We know that we see it more in adults over 40. So this is just a good picture to kind of help you. Metabolic syndrome. These are clinical traits that will increase the risk of development of cardiovascular disease when they occur together. So if you have 3 or more of these together, then you're very, very high risk. Okay, and basically when you look at these, they all have something to do with central obesity, low HDL levels, and when you look at HDL, that's your highly desirable, so your good cholesterol. So there's elevated triglyceride levels, elevated blood pressure, elevated fasting blood glucose, and elevated CRP levels, which is an indication of systemic inflammation. Gestational diabetes. First of all, let me say I will bet that you're going to find a question on metabolic syndrome somewhere, so I would memorize all those numbers. Gestational diabetes just means that the patient or the person exhibiting the signs and symptoms was pregnant. So in order to have gestational diabetes, you must be pregnant. The risk factors are listed for you here. And pregnant women at risk should be screened to prevent morbidity and fetal mortality. So if somebody's at risk, they would need to be screened because the infant can actually die and there can be some problems with mom. So when we look at diagnostic with gestational, if they're high risk and their fasting plasma glucose is greater than or equal to 126, or casual glucose, meaning no reference to food, would be greater than 200, or their hemoglobin A1C level would be greater than or equal to 6.5%, then you can give an accurate diagnosis of gestational diabetes. Now, if there's no signs and symptoms of the disease, then you can't rely strictly on a one-time reading of the fasting plasma glucose or a casual glucose. So if you're doing it with those, you would have to confirm it on a subsequent day. Okay, but an A1C level, again, that's a reading an average over 2 or 3 months. So if we did that on a person, we could get an accurate finding with on one time. So a normal or low risk lady that was pregnant at 24 to 28 weeks, they would do what we call an oral glucose tolerance test, and they would do a 50-gram ingestion of sugar and then draw their blood sugar an hour later. If that was greater than or equal to 140, then, or if they did if it was greater than or equal to 140, then they would need to do a second oral glucose tolerance test on another day where they drink 100 grams and then they do a 3-hour blood draw. And again, if at 3 hours, if it's still greater than or equal to 140, then that's a positive diagnosis during gestational diabetes. Type 1 versus type 2. Again, I'm not going to go through each one of these slides. I'm going to do that in class, but type 1, typically this is your thin person or thinner person. I think this slide right here. Type 1 is usually sudden onset, occurs at any age, but we usually see it in a young person. Their habits or body type is usually thin or normal shape. They're more prone to ketoacidosis. Autoantibodies are usually present, meaning it's sometimes an autoimmune disorder. And endogenous insulin, meaning is there insulin produced in their body? I'm going to tell you where it says low, it's usually absent. There's a complete lack of insulin production in type 1 typically. The prevalent is that it's less prevalent than type 2. On the flip side of that, you see type 2 diabetes more often in adults who are obese. We rarely see ketoacidosis with type 2 diabetes because there is some insulin usually that is produced. It is the most prevalent form of diabetes that we're going to see and discuss. Very high in the genetic. You see 90% coordinates in identical twins. And so the body can produce normal amounts of insulin. They might be decreased or might be increased. So these are some of the main findings to think about when you're talking about type 1 versus type 2. So when should we begin testing? If there's very small amount of risk factors for you, 45 years or older on all individuals, okay? But earlier than that if there's an increased risk. And so you have your diagnosis numbers there. I kind of gave them to you just a second ago as well. And let's see. So monitoring diabetes treatment, we would do fasting blood glucose levels. We'd do glycosylated A1C levels, which I've already talked to you about. The thing that I haven't talked to you about is urine tests. So at home, patients can actually urinate in a cup and do a dipstick where they put this little piece of paper in there and look at it, and it can tell them if they have glucose in the urine or if they have ketones in the urine. And those are very helpful, especially for patients at home, because it helps them control, their risk of developing DKA or ketoacidosis. So, and then self-monitoring of blood glucose, again, that would be like capillary blood glucose sticks. So if you see capillary stick or capillary blood glucose, that's when they stick your finger. And remember, I told you there's going to be about a 10 to 15% difference when they get a blood draw. Now, this is just a correlation of our hemoglobin A1C levels. So when we talk about a 6% or a 6.5%, this is what you need to understand. Basically, a hemoglobin A1C level of, let's just say, 7% would mean that on average the patient had a blood glucose level of 154, okay, on average. So what you need, I don't expect you to remember each one of these numbers and what number they correlate with, but it is a good tool to keep with you. This is an updated guideline. This is from 2015. It helps you understand where your patient is at. So if I told you that the goal for diabetics is to keep their A1C level less than 7%, then that would mean less than 154 average glucose, right? So you say, well, why don't we want them any lower? Well, because it's going to be hard to get them into the low normal ranges most of the time. So what the ADA has come up with is a goal percentage for a patient that is already a diabetic. If we can keep their hemoglobin A1C number below 7, that is our goal. Now, there will be some differentiations with patients that are renal failure and things like that, but as a good rule of thumb. So when you see those diagnostic criteria right here as A1C greater than or equal to 6.5% would be diagnostic, that kind of gives you an idea that the blood glucose is consistently 126 or more, and that's where those other findings and numbers came in. Moving on, really kind of going to go briefly through these acute complications. The acute complications are diabetes ketoacidosis, hyperglycemic hypoosmolar state, hypoglycemia, and then we talk about the Somogyi and Dawn phenomenon. Now, those two you're going to have to look up and try to read in the book more. I don't touch on them that much on this slide. DKA. So again, when we look at DKA, we've already talked about it's more common in our type 1 diabetics, characterized by characterized by hyperglycemia, ketosis, which would be like ketones in the blood or in the urine, so ketonemia or ketonuria, metabolic acidosis, which we've already talked about. In metabolic acidosis, you would have low bicarbonate levels, less than 15, and a low pH, 7.3, about 7.30-ish. So what is a definitive diagnosis? These same things, but the actual values. So hyperglycemia greater than 250, ketones in the urine, in the blood, and a pH of 7.30 or less, and a bicarbonate of less than 15. What brings this on? A patient has type 1 diabetes. They experience a lot of stress or illness, or maybe during pregnancy. They're not taking their medications. They become extremely thirsty, which is called polydipsia. Frequent urination, which is polyuria. So they're peeing a lot, they're drinking a lot, they're having some abdominal pain and tenderness. Their breath gets what we call a fruity smell, a fruity tint to their breath. And that's ketosis that you smell coming through there. You see low blood pressures and elevated heart rates. Something called Kussmaul respirations is where the rate and depth of the respirations will actually increase. And that's classic for DKA. So there's others, that blurred vision, that's usually a big thing. Vision, drowsiness, confusion, some of those things you'll see manifestations or people will complain of. Now, HHS is another acute complication that we might see, and this one is usually more common in our type 2 diabetic, And the reason for that is that they are used to having elevations in their blood glucose for longer periods of time. So whereas the DKA, we say the blood glucose is greater than 250, this one, we're going to talk about definitive diagnosis and it's significantly more elevated blood glucose that you're going to see. Okay, so what we see here is it's characterized, again, same thing, hyperglycemia, but part of the definitive diagnosis is that the blood sugar is actually greater than 600. It's pretty high. We have what we call a hyperosmolar state, where the plasma osmolarity is increased. So this patient is like more concentrated. The blood is actually literally thicker. And so that level would be greater than 320. So a hyperosmolarity of greater than 320. When this occurs, the patient is very dehydrated, and we do not see any ketosis occur here. It's a hyperosmolar state because sugar or glucose is an osmolar molecule, and it causes water to be pulled out of the cells. Okay, what we see here is often mistaken as a stroke in the patient because there's visual disturbances. There's like hemiparesis, which is like drooping or like loss of function on one side, or seizures. Some of the big causes could be pancreatitis, infection, giving somebody like parenteral nutritional solutions, like if we're giving them food through the IV or through their NG, those kind of things. Increased resistance to the insulin that's available or circulating, or just excessive carbohydrate intake in somebody who is diabetic and their body just cannot process it. So weak manifestations, they're usually really weak and dehydrated. Again, you see the polyuria. You see polydipsia. They have neurological signs and symptoms. I would look those up in the book. Visual hallucinations and aphasia, where they can't speak well, or they have the Vinsky reflex. Again, the hemiparesis. These persons with HHS are high risk for thrombolytic events, which is a clot or stroke. Okay, because the blood is so hyperosmolar and it's so thick, they're at risk for clots. So that's a big thing that we watch for. With hypoglycemia, it just means your blood sugar's low. Okay, typically a glucose below 60, usually we say 45 to 60, you start to kind of feel hungry and sweaty and cold and clammy. So there would be decreased mental alertness. With that, you're hungry. The neurological symptoms are just kind of like they have a headache and they're shaky. They irritable and fatigued. Lots of those seizures and coma that can be evident. How does the skin react and why it becomes cold and clammy? Because of vasoconstriction. It's trying to shunt the good blood where it needs to go. And the major complication the worst thing that could happen would be a coma or death. So here's a picture of hypoglycemia. They get tired. You see that, restless, excessive hunger, diaphoresis, which is sweating, irritability, tachycardia. But eventually they can go into a coma and just not wake up. Some people just don't wake up. Also, you see here is another picture they gave you to kind of help, give you an idea of what's going on. Again, I'm not going to cover the Samaji effect and the dawn phenomenon very much. Just know that they both deal with waking up in the morning with elevated blood glucoses. Typically, the Samaji, they have a pretty severe hypoglycemic effect during the night, and their body kind of overcompensates for that. And they don't even know that it happens most of the time. Whereas the dawn phenomenon, there's no hypoglycemic effect. It's kind of like a steady increase in blood glucose from nighttime when they go to bed till about 5 to 9 a.m. in the morning is when we get the really elevated levels. Some of the acute complications, some of the chronic complications, we just talked about the acute ones, are going to be these. You have microvascular, macrovascular, and then you have diabetic foot ulcers and infections. With your microvascular, you need to understand about peripheral neuropathy. There's a difference between somatic neuropathy and autonomic neuropathy. The somatic neuropathy is more common. It's a distal symmetric loss of function, kind of what we call a stocking glove pattern. It usually occurs first and associated with diminished perception of vibrations and pain and temperature, so they don't feel things like they should in their feet. A lot of times these patients will step on things and never know it. Sometimes it can be painful and associates with like hypersensitivity to touch, like a burning pain. I tell you, so peripheral neuropathy. Again, it's just to recap, it's a damage or thickening of the vessels that supply the peripheral nerves, and it results in damage and a miscommunication with the brain. So, like I said, they don't feel things like they should. They don't feel pain as far as like deep pain. They don't feel like they'd step on a tack and never know. The tack would just be sitting in their foot for days. Autonomic involves disorders of the sympathetic and parasympathetic system, like cardiac responses, impaired motility of the GI system, inability to empty the bladder, and so forth. Nephropathy, basically what's happening here is your kidneys are overworked, okay? They become enlarged, they have nephron hypertrophy, they have hyperfiltration, they're working in overdrive trying to filter out all this glucose that you keep pouring into the system, okay? And basically, they just wear out. Okay, so it's the leading cause of chronic kidney disease. So diabetic nephropathy is the leading cause of chronic kidney disease. We have risk factors would be like genetic predispositions, poorly controlled blood pressures, so elevated blood pressures that aren't controlled, poor sugar control, so hyperglycemia that is uncontrolled, hyperlipidemia, smoking. We see it in the Native Americans, African Americans, Hispanics. You know, those are more risk for the nephropathy. One of the initial manifestations, though, with nephropathy is that we see an increase in urinary albumin excretion. These people are losing quite a bit of proteins in their urine, maybe even over 30 milligrams a day. So greater than or equal to 30 milligrams a day. And we see a hemoglobin A1C level of greater than or equal to 8.1%. So that's pretty significant. So type 2 diabetes and smoking, those increase your risk of nephropathy as well, major. Retinopathy, typically we see this with type 1 diabetics if they've had diabetes for 20 years or more. Almost like 60-70% of those type 1 diabetics are going to have retinopathy. So that's very common. We also are seeing it in type 2 that have some degree of poor glucose control, hypertension, smoking, and dyslipidemia. But it's characterized by abnormal retinal vascular permeability. They also can have like little aneurysms that form and cause hemorrhages. And so I got some pictures here for y'all to look at. This would be your normal vision, and this would be what somebody with diabetic retinopathy is actually seeing. So it's kind of debilitating, and it kind of sucks because eventually they can go blind. This is just a picture that I found that I thought was excellent about peripheral neuropathy. Remember that they can have some like hypersensitivity and light pain to light touch, but they would not feel something major like stepping on a tack or something like that. And this, I know this is quick and I'm just skimming through, but this is hitting the high points. Macrovascular would be coronary artery disease, cerebrovascular disease, so strokes, heart attacks, chest pain, those kind of things. Peripheral vascular disease, meaning the blood flow in your lower extremities or your periphery. Those are macrovascular. What you need to understand is that diabetes is a major risk for atherosclerosis and coronary artery disease, CVAs, and PVD. These are increased 2 to 4 times in diabetics, okay? These things occur frequently. Obesity and hypertension, elevated blood glucoses, elevated insulin in the blood, elevated lipids, altered platelet functions, and increased CRP levels, which is systemic inflammation. These are all things that we would see in relation to our macrovascular complication. Typically, type 2, we see more commonly manifest with these at the time of their diagnosis. So when they're actually just getting diagnosed, they already have some forms of heart disease and brain disease and vascular. The last things that we're talking about is diabetic foot ulcers. And these, it tells you here, is the most common complication leading to hospitalization among diabetics. So with that being said, the distal symmetric neuropathy or the somatic neuropathy, peripheral neuropathy, is a major risk factor for foot ulcers. And these are just a couple of pictures that I want you to seriously look at. What you're looking at here is an ulceration that develops on the foot of a patient, and they probably do not even feel this. Okay? This toe has already been amputated. There's been a toe in here and here. It's been amputated. Very, very common. Okay? Type 2 diabetics or very long ongoing type 1 diabetics. In this situation, you can kind of see the redness and the swelling and puffiness, and they've already had all of their toes cut off. But right here, there's another ulceration that's starting to occur. Okay? So I want you to think about these things when you think about your complications. This is a picture of a patient that has peripheral vascular disease. Okay, not only do they have peripheral vascular disease, impaired blood flow getting to these tissues because of the atherosclerosis in diabetes and the vessels, but they also have an infection, okay, going on. So this would be like a ulcerative stasis infection. Not that you have to know what kind it is, but I want you to understand that there's multiple things going on here. This patient has, like I said, some PVD going on, so their blood supply is low, and they've developed an infection of the skin, which this will probably not heal. Okay, and so what happens is this infection becomes so bad, so long, it causes osteomyelitis, which is a bone infection, and this patient will likely have to have their leg amputated pretty high up. So, and just to end this, I thought this was a cute slide. He says, I'm learning to manage my type 2 diabetes with my insulin. And you can see he's just steadily pouring in the food and all the junk, and he's sucking down the insulin. Now, I don't want you to confuse this because we talked about insulin being primary with type 1, but we know that sometimes insulin is used with type 2 diabetics to help them gain control of their disorder. Okay, but I just thought the cartoon was really cute. So that concludes our lecture on diabetes. I hope that you are able to come to class and gain some information as well from there, and this helps kind of set the information that you hear in class or that you've read in the book and help set it into for your learning.